Many cases of sudden death and severe disease are being reported since the rollout of the COVID-19 gene-based vaccines. Early on, several doctors and scientists hypothesized that the COVID vaccines would lead to several complications, including autoimmune disease, blood clots, strokes, and more. Additionally, the Vaccine Adverse Event Reporting System, or VAERS data, showed a strong correlation between the vaccines and adverse events. The warning signs were always there, but most of the evidence that is discussed surrounding adverse events is focused on the numbers. This many more sudden deaths, stillbirths, or cases of myocarditis, for example. So how does one determine, in an individual case, that the vaccine was the cause of death or the adverse event? It is done through pathology. An early pioneer of pathological investigations into vaccine adverse events was Professor Arne Burkhardt, a senior, highly accomplished pathologist from Germany. Professor Burkhardt came out of retirement in 2021 to examine the autopsy and biopsy materials of vaccinated patients, both living and deceased. The work of Professor Burkhardt not only provided strong evidence of vaccine causation, it substantiated the professional medical hypotheses of doctors and scientists around the world. Unfortunately, in May 2023, Professor Burkhardt passed away. But shortly before his death, I had the chance to interview him in his laboratory in Germany, in which he gave a detailed and compelling account of his work. During the next 2 hours, you will hear Professor Burkhardt once more, in his own words, discuss his findings, his motivation, and what he hoped for the future of the fields of science and medicine. This is one of the few extensive English language interviews with Professor Arne Burkhardt, and it is one of his last. I'm journalist Taylor Hudak, and today I'm in Reutlingen, Germany at the Laboratory of Pathologist Professor Dr. Arne Burkhardt. Professor Burkhardt is a highly esteemed pathologist with more than 50 years experience in the field. Since 2021, he has examined 75 autopsies in patients who died shortly after vaccination, as well as 41 biopsies in living persons to determine if the COVID-19 vaccinations caused either the death or disease in the patient. All right, Professor Arne Burkhardt, it is my pleasure to be here in your lab today and to speak with you. I have been following your work very closely for the past year in particular. So why don't you just introduce yourself to the viewers, explain your credentials, your qualifications, as well as your contributions to the field of pathology.
Well, first of all, of course, I would like to thank you for the opportunity to talk to you and for those people who are interested in this field. Well, as you said, I've been in the field of pathology for many years now, and many years also in scientific projects involved. The latest book has appeared in just last year, so I think I'm still in the business, so to say. Actually, beginning of 2021, I wanted to close this laboratory and go into retirement. And just at that moment, the vaccination campaign started in Germany, and it only took 3 months. That was in March 21, that the first reports came to me about serious side effects, and especially cases of people who died in timely connection with the vaccination. And in most of these cases, even if an autopsy was performed, it was stated, well, this was a natural death, and the relatives were suspicious about this, and they didn't accept this because usually these people were very healthy before vaccination. So they contacted me and other pathologists about a second opinion. Now, a second opinion is something very usual in oncology, because to type a certain type of cancer, you have sometimes many pathologists look at it and they have different opinions and so on. But in autopsy, usually the autopsy is considered something like a gold standard. If you do the autopsy and you have a result, you accept it. And maybe only once a year it happened that somebody said, well, there's an autopsy and I don't believe the results, please look at it. But suddenly these were many, many relatives that came to me, and sometimes also attorneys who turned to me and asked if I would be willing to do this, because usually many other pathologists just refused this. And actually I said, well, I can look at 5 or 6 cases and probably everything is okay, and this will be it. But then I received the first 5 cases, and I saw things that were very unusual, and lesions that I had not seen before in this context. So actually I contacted other pathologists and also university institutes, and asked them if they would continue this work and take over my project, because actually I didn't want to do this and go into retirement. But actually some of the pathologists that I contacted first said, well, yes, we do it, and we have some support from the government for these projects, and we will do it. But after a while, when it should have been started, they drew back and they said, well, we don't want to have anything to do with it, please leave us alone. So I was forced to continue my work, and as a consequence of our first results, luckily I had a second experienced pathologist, Professor Lang from Hanover, who helped me and who was able to confirm what I saw.
Of course, the initial diagnosis was either death caused by some natural causes or another cause. So how do you account for the discrepancy between your second opinion findings and the initial cause of death?
Well, as you said, there was a discrepancy in almost all of the cases that we saw. The pathologist or the coroner who did the autopsy claimed it was a natural cause of death, or some stated it was unclear. Okay, that's always a very honest diagnosis. The problem is that quality of autopsy, as it is practiced now in Germany, I think has dramatically declined in the last years. When I learned pathology, this was the main focus of the institutes of pathology was autopsy. But now it's mostly bioptic diagnostic, which of course is also very important. But pathologists have lost the interest in autopsy, and usually they are satisfied if they find something plausible as a death. So if they see a discoloration of the heart muscle, well, they say, well, this is an infarction of the heart, and if the person is older than 50 years, I mean, that's always plausible. And so it is, they no longer look for the causes behind what they see. I mean, even in many cases, histology is not done. That means the tissue is not examined in the microscope. and you cannot make a diagnosis without, or not many diagnoses you cannot make without looking at the microscope.
And that's what you did. You used histopathology, is that correct?
Yeah.
And can you explain to us what that is? We will also show these images here to help explain the use of histopathology.
Yes, well, first of all, you take a small specimen from the tissue that you want to examine, and it has to be fixed because it's soft and you cannot cut it, and you have to perform very thin sections, thousands of millimeters thickness, and if you put them on a glass slide so they are fixed, then they don't have any color at all. Only few elements have color, like the red blood cells. That's why they are called red blood cells, but all the other cells do not have any color. So you use special stains to make structures visible. And there are two ways to do this. One is that you have a chemical affinity of the dye, and you see special structures. And the other thing is that you have antibodies that bind to certain proteins that you then see in what we call immunohistochemistry.
Let's focus on this image here. This explains on the left, or it shows rather, unstained prostate gland tissue and kidney tissue, and then on the right we see it labeled as HE stain. Can you just explain why you would use this method when examining a specimen?
Well, actually the H&E stain, which is hematoxylin eosin abbreviation, is a standard coloration or stain used in pathology. Almost all examinations start with the H&E stain. So
it's a very common practice to use this staining method, and does it help you differentiate between the different structures that you were looking at?
Well, at most structures, at least.
I'm just showing these images to the viewers now so they can be prepared for what they are about to see as we begin discussing your own work and the images from your studies. But if we could just take a look here at this next image, this is liver tissue stained with HE. Can you just describe why it is so useful to stain a specimen, again, with HE?
Yes, well, you see the blue points, these are the nuclei, as I said, and they may be enlarged or there may be multiple nuclei in a cell. And then, of course, you see the cytoplasm, which is clearly red here, and you can see there may be changes there too. There may be inclusions, there may be vacuoles, there may be foreign bodies in there. So all this you can see.
In addition to the HE stain, there are also various special staining methods that highlight specific structures and disease-related features. Here we see two examples from Professor Burkhardt's findings. In the image on the left, the Congo red stain is used to highlight a ring of amyloid within the vessel, which is a darker red color. In the image on the right, the Prussian blue stain is used to highlight iron deposits in the periphery of the vessel. Later on in this interview, Professor Burkhardt will explain what the findings mean. I next asked him whether the pathologists who had performed the initial autopsies had also examined the tissue samples under the microscope.
Those autopsies that were performed in legal institutions, usually no histology at all is done.
Is that unusual to you?
No, this has been practiced since the beginning of legal medicine, actually, and it is upon the prosecutor if he orders histology to be done or not. So, of course, if there's a clear case, like somebody has been stabbed by a knife, I mean, you don't have to have a histology for that. And so the prosecutor says, well, this is okay. But if it is stated unclear, cause of death is unclear, then the prosecutor has to decide whether histology is done or not. But Actually, in many cases that I have seen now, even if the coroner said cause of death is unclear, no histology was ordered. In many cases, toxicological examinations were done, especially in young people who die suddenly of unexplained causes. Often drug abuse is suspected. But in all of these cases that we examined, this was negative.
So in your own studies, upon your second opinion, you did use the histopathology, whereas it was not done at the initial diagnosis.
Yes, yes.
So that accounts for the discrepancy in your second opinion compared to the initial diagnosis.
Usually, yes. As I said, in the legal institutions do not histology as a routine work, but they preserve specimens. And these specimens are guarded for 2 or 3 years, and so we got these specimens and we did the histology.
Now I would like to focus on the pathological changes commonly seen in vaccinated persons. And so many of us who are not medical professionals have heard of myocarditis, which is inflammation of the heart muscle tissue, and you were able to observe this in your own studies. So I would like to now discuss these two images here. This shows on the left normal heart muscle tissue, and on the right, lymphocytic myocarditis after the vaccine. Can you explain to us the observed abnormalities that you see with the image on the right?
Well, on the left side, you see the muscle cells, which are elongated and have these long nuclei. But on the right side, you see that in the middle between these muscle cells, there are small blue dots, which are the nuclei of lymphocytes. Lymphocytes are immunologically active cells, and apparently they have been attracted by some antigenic material that is in the heart. Now, of course, 1 or 2 lymphocytes are always seen in a section, but not aggregations like that. You may compare this to the police controlling a city, for example. Now, if you see 1 policeman or policewoman, that's okay. I mean, that's normal. If you see 2, it's still not alarming. But if you all of a sudden you see 50 policemen, then you know there must be some trouble somewhere in the city. And that's the same in the heart muscle. I mean, if I see 1 or 2 lymphocytes, that's normal. And they control, so to say, if there's anything wrong. But if they are aggregated like this in clumps, there's something wrong, and that's myocarditis. By the way, myocarditis, as a consequence of vaccination, of the so-called vaccination, is now internationally recognized. I mean, this is nothing that we have to prove anymore. This has been proven and is a solid scientific standard.
Absolutely. Now, with this particular case that we are referencing here, do you know what symptoms the person had? And if not, what symptoms would you expect one to experience in a case like this?
Well, the main symptom is fatigue and physical deterioration, the necessity to sleep after some sportive activity and physical strain. So actually we had 31 cases among these 75 cases where it was stated they died of heart failure, and normal heart failure like rhythmogenic failure and so on. And of these 31 cases, actually in 15 cases there was a perimyocarditis, inflammation, and in the other 16 we saw what is called a microangiopathy, that is changes in the small vessels that have nothing to do with arteriosclerosis, which of course is normal in older patients. So this is the myocarditis.
prior to the rollout of the COVID-19 vaccinations, when you look back on your career, how often did you see myocarditis then compared to now within the past 2 years?
I don't think I saw myocarditis more than once a year. And at that time we did between 1,500 and 2,000 autopsies a year. And as I said, 1 or 2 cases a year. And now this is one of the most common diagnoses, especially in younger people.
Professor Burkhardt has explained that clusters of lymphocytes in heart muscle tissue indicate inflammation. A large cluster of lymphocytes is also seen in this sample of lung tissue. The sample is from an 82-year-old woman who died 40 days after receiving a second injection of the Moderna vaccine.
You can see a small vessel, and there's lymphocytic infiltration around it, which is not normally in the lung. And so this person definitely must have had some deficit in the gas exchange of the lung.
We next discuss the case of a 70-year-old woman in whom Professor Burkhardt found striking changes within the thyroid gland. A tissue sample from the woman's thyroid gland is shown on the right. On the left, we see some normal thyroid gland tissue for comparison.
Well, yes, on the left side you see the what we call follicles, which contain the thyroid hormone, and the hormone is of course needed for the body. And on the right side you see that these structures are lacking, and instead of these structures there's lymphocytic infiltrations, which we already have seen in the other pictures. So these lymphocytes destroy the thyroid tissue, and this is a well-known autoimmune disease, which is known for many years, and it of course occurs without vaccination. But after this vaccination, we see it more often. And in these people that we saw the autopsies, in many cases this disease was not known before. So it probably started or was at least promoted by the vaccination. We asked about if there were symptoms before, and nobody knew anything about thyroid disease in this person.
So this person did not have any pre-existing condition that could maybe put them at risk for something like this?
No.
Interesting. Okay. Is this damage reversible?
Once the thyroid glands is destroyed, this is not reversible. It does not have the capability of reconstruction. But it can be treated, of course, by giving the hormone medical treatment.
The lymphocytes are a common theme among the findings discussed thus far and will continue to be discussed in subsequent cases. So how do mRNA vaccines cause lymphocytes, a type of white blood cell, to attack healthy cells? An mRNA vaccine particle consists of a modified RNA molecule, which is contained in an envelope of fat-like molecules or lipids. Once the vaccine has been injected and comes into contact with the body cells, the lipids which encase the mRNA molecule help the mRNA traverse the membrane which surrounds the cell, allowing it to enter the cell. The mRNA binds to the ribosomes within the cell, which are the cell's little protein factories. The ribosomes read the information on the mRNA and create multiple copies of the spike protein molecule. Intact spike protein molecules will transport to the cell surface, and some spike protein molecules are fragmented, and the fragments are taken to the cell surface. There, they are presented to the cells of the immune system by a specific carrier molecule called MHC1. MHC1 is the orange figure shown here. Think of MHC1 as a passport, and the antigenic peptide, or the spike protein fragment carried by MHC1, as the individual details printed within the passport, such as name and photograph. T lymphocytes, which happen to possess T cell receptors which match these antigenic peptides or spike protein fragments, will recognize the MHC1 in combination with the spike protein fragments it carries and then bind to it. If a cytotoxic T cell recognizes and binds its matching antigenic peptide, then it will attack and destroy the cell which presents it. This is a necessary step in antiviral defense. However, in the context of vaccination, it is unnecessary and potentially dangerous, as the immune system will attack healthy cells. Lymphocytes occur in the spleen and the lymph nodes, but are also seen in the blood. The lymphocytes are fairly small, are round, and are typically stained dark purple. If lymphocytes appear in large quantities in tissues other than the lymph nodes or the spleen, this usually means that either a viral infection or some autoimmune disease is in progress. A third possibility would be the rejection of a transplanted organ. Now we must contemplate another novel mechanism, namely the attack of the immune system on the vaccine-expressing cells. The vaccines are known to enter the bloodstream shortly after injections, and this does raise questions as to how it could impact the blood vessels. So what have been your observations on this point?
Well, first of all, the spike protein, which is on the one hand produced by the virus in viral infection, but on the other side is induced by the vaccination in the body. But these two possibilities have completely different access to the body cells. If you have the viral infection, the toxic spike protein first has to pass through the epithelium, and the epithelium is immunocompetent and already has the capability of detoxification and destruction of harmful elements. But the endothelium, which is the lining of the vessels, is not an immunocompetent cell structure. So the toxin that is entering into the bloodstream and into the lymphatic vessels directly hits the cells that are not able to defend themselves. So they may be destroyed. They may be destroyed by toxic action, and they may be destroyed by immunologic attack.
Blood vessels are preferred targets of lymphocyte attack after vaccination. Both the large and small blood vessels can be afflicted anywhere and everywhere in the body. This is because the vaccine will distribute from the injection site to other locations in the body, mainly through the bloodstream. This image shows a dissection of the aorta, the largest blood vessel in the body. An aortic dissection is usually very rare. It is a serious condition in which a tear in the aorta allows blood to rush into the vessel wall, causing it to split or dissect. This patient was a 55-year-old male who died 21 days after the second injection. What is being observed here, and why is it significant? Can you talk about this case in particular?
Yes. You see a section of the aorta, and if you see on the left side, there's a solid wall, which is kind of yellow coloration. Yellow is the color of the elastic fibers, by the way. And then you see that there's a split formation in the middle, and then there, on the right side, there are actually two walls. And in the middle, there's this black material, which actually is blood. So there has been blood flown into this dissected aorta. The media, what we call the media of the aorta, has been destroyed, and the blood has entered. And once the blood has entered there, and then the aorta may rupture, and the people die of blood loss.
I also want to look at this image from a microscopic viewpoint. So here again is the dissection of the aorta. This is the same aortic wall, but this time it is stained with HE, which we talked about earlier, and placed under a microscope. So here are the two images. Can you describe in a greater detail what we are seeing here? now that it's under the microscope and there's also dye applied, what can we tell about this aortic dissection?
Yes, if you look at the left side, on top you see the lumen of the aorta where once the blood was flowing. Then there is the inner section of the aorta, and below there's a dissection, and then you have the outer wall. So as I said, the wall is split into two. And you see the red here is the bleeding, and then you see this line of blue dots. These are inflammatory cells. And on the right side, we have a higher magnification. And here you can see that actually on the left side, you see the inner wall of the aorta, and then on the right side, the bleeding. And in the interface, there is this infiltration of mostly lymphocytic cells. Some macrophages are also there. Why do we do this? I mean, the dissection of the aorta you can see without the microscope. But of course, a dissection of the aorta may have different causes. And one is, in older person, the arteriosclerosis. But if you look here on the left side again, you don't see any sign of arteriosclerosis here.
So you were able to rule that out as the cause?
I can rule this out.
Okay.
The second thing that has to be ruled out is the genetic defect of the connective tissue, which may lead to this type of aortic rupture. It appears in younger persons, and this usually does not go along with any significant inflammatory infiltrates. So the inflammatory infiltrates prove in this case that it is not a genetic defect. And we can further make this plausible because we did the immunohistochemistry for the spike protein, and it is selectively located in these areas. So this is an additional proof.
Just to tie it all together, I want to make note that this methodology that you use was not used during the initial autopsies. Is that correct?
Yes, this is correct.
Okay. Before the rollout or implementation of the COVID-19 vaccines, how common was an aortic dissection?
As I said, we did about 1,500 to 2,000 autopsies a year, and I might say it might have been 1 or 2 a year at that time. And in this series of 75 autopsies that we have re-examined, we saw 5 ruptures of the aorta with consecutive deaths. And actually, in those cases where histology from the aorta was taken, smaller areas of dissection, especially loss of the elastic fibers, I think we come to this later, can be proven in many, many cases, in almost all cases. Some of these findings are minimal.
Okay. So we know that the COVID-19 vaccines induce blood clotting, and this was predicted by several doctors and scientists before the COVID-19 vaccines were made available to the general public. And these 2 images here, which are not from your own studies, but from a general archive or published studies, show vasculitis, which is inflammation of the blood vessels, and that can induce blood clotting. So can you just explain for us what is being observed in these 2 images, and in particular, what staining method was used? When you describe this here, it's going to help provide a better context for the listeners as we begin to discuss images from your own studies.
On the left side, you see the standard H&E stain, and you see this circular structure, which is a little bit more red. That's the inside of the vessel, and it's a thrombus formation. And you can see where the arrow is. You can see that the endothelium is destroyed. So one of our main results, we stated that the endothelial damage is one of the main causes of the complications.
What happens if you have endothelial damage?
Well, if the endothelium is damaged and discarded into the vessel lumen, then the basement membrane and the extracellular matrix of the vessel wall is exposed to the blood. And as soon as this happens, the body wants to heal this, and the thrombocytes come, and the thrombocytes are those that initiate a thrombus formation. So thrombus formation actually is a normal healing process, and in this case, healing process of damage that has been triggered by the vaccine.
Okay. And then if you would like to go ahead and describe for us the image on the right, and I believe that immunohistochemistry was used in this image, because we see different colors. We see some brown, some black even. If you could just describe what is being observed here.
Well, you see these brown staining, and this is fibrin. So besides thrombocytes, fibrin is the main component of a thrombus. And so we can actually prove that in this case there's a thrombus formation.
And that means a blood clot?
Yeah, that's a blood clot, yes.
Okay. Continuing with our discussion on the blood vessels, there has been evidence of lymphocytic inflammation of the small blood vessels. Here we have an image from Dr. Michael Mertz. Can you explain to us the differences we see here from the image on the left, which is a normal small blood vessel, compared to the image on the right, which is a blood vessel attacked by the lymphocytes? What observed differences do you see?
Well, actually on the left side you see this small vessel, and inside there are these red dots which are red blood cells, and then you can see these elongated spindle-shaped nuclei that form something like a wallpaper outlining and protecting the vessel. And if these are destroyed, as I said before, then thrombosis might happen, and on the right side actually you see this microthrombus, which usually mainly contains thrombocytes and some fibrin. And very important, you see that instead of the normal myofibroblasts that form the vessel wall, there's an infiltration of inflammatory cells.
Now, these next two images and cases that we will discuss are from your own studies in which you observed vasculitis of the small blood vessels in the brain. This is now the second time that we mentioned vasculitis, so just a reminder for everybody listening, that is an inflammation of the blood vessels. If you could again, for us, just describe what is being observed in these two images here.
Yes, well, actually, this is one of the most alarming findings that we had from the beginning on, that if you really look closely at these, at the brain tissue sections, you find this vasculitis in almost all cases. In many cases, it's a very discrete, but you have to look for it. And these are two images where you can see, you really have to look closely to see that these small vessels in the brain, the endothelium is swollen, but then there are these small blue dots. These again are lymphocytes, which aggregate around these small vessels.
And lymphocytes cause inflammation.
The fact that lymphocytes are found there means that there's some inflammation, probably triggered by some antigenic structure, in this case maybe a spike protein or something from the vaccination. And as I said, this is a finding that in minimal degree is found in almost all of these people who died after vaccination. And actually we have seen it also in one needle biopsy from the brain. We come to this later. And in many of these cases which have more pronounced inflammation of the vessels of the brain, there have been transient defects like loss of speech for a few hours, unconsciousness for some hours, blindness for some hours, The brain is if there's no major inflammation and no hemorrhage, these people, the brain is able to compensate again. But of course, this is a very striking side effect.
So just in order for me to summarize what you had just said, this finding here was one of the most concerning.
Yes.
It is also one that is very commonly seen in people who have died post-vaccination.
Yes.
And it can, oftentimes individuals with this complication have had periods of blindness, inability to speak properly. Is that correct?
Yes, yes. Now, just to get this clear, I mean, they did not die from this. This is something we find. We find other cases where there's blood bleeding and hemorrhage in the brain, and they died of it. But this is just a side effect which may be compensated and healed to a certain degree.
So somebody who's listening right now, or anybody could have received the COVID-19 vaccine, they could have this very issue, experience some symptoms, and not even know that they are experiencing this?
Yes, exactly. And actually, in some cases, change in the character of these vaccinated is reported. Sometimes it's reversible, and apparently in some cases not. And this may be one of the reasons.
In addition to lymphocytic inflammation, Professor Burkhardt also found other forms of damage to small blood vessels. These 3 images show lesions of these small blood vessels in the brain and heart. Images A and C show these small vessels from the brain of an 87-year-old woman who died 302 days after receiving a second Pfizer vaccine. Image B shows these small vessels from the heart muscle tissue of an 81-year-old woman who died 23 days after receiving 1 dose of the Pfizer vaccine. So if you could just go ahead and describe what we are seeing in these 3 images.
Well, in all 3 images, you see lesions of the blood vessels, of the smaller blood vessels. And on the left side, this is a small vessel from the brain. And in this case, there's no major inflammation, but we have this blue stain, and the blue stain means iron deposition. And iron is deposited where there has been bleeding before. So the erythrocytes contain iron, and it is deposited in the tissue as what we call hemosiderin. And hemosiderin is a very strong indication of bleeding in this vessel wall. Now, this person at this point at least was lucky, because this bleeding was stopped within the vessel wall, and it did not go outside into the brain tissue. And if you look at the right side, again, this is from the brain, and this is a stain which we call Congo red, but it stains especially the elastic fibers, and usually these small vessels are completely surrounded by elastic fibers, so that they will not rupture. And you can see that in this part, it is there are elastic fibers. Now, they are also not normal. They are clumped together and discontinuous, but in this part, they are completely lacking, and you see that the small vessel has what we call an aneurysm. And now this of course could rupture at any time, because there's no elastic lamella anymore which may contain it. And in the middle you see that also the small vessels in the heart muscle are affected, and in this case the endothelium is swollen, and there has been a deposition of some acellular red-stained material, which is apparently related to what we call amyloid, and in some cases also related to prions. And these are proteins that may be derived from the spike protein, and deleterious effect is that the body cannot get rid of them. They are not digestible by macrophages or other inflammatory cells.
The image in the middle, it is labeled amyloid protein deposits. Can you just explain what that is?
Well, this is this strange type of protein. It's a misfolded protein which by this unnatural structure cannot be disintegrated by the body. And so it remains in the body. And as I said, there's a certain disease, amyloidosis, which is very rare and develops after many years of infections and something like that. But we find similar proteinaceous deposits after vaccination, and they have a different. They are probably not identical, but they are related to it. That's why we call it amyloid-like.
Now, how do these changes to the blood vessels affect organ function?
Well, if you look at the middle picture, of course, you can see that this small vessel is practically occluded. I mean, there's maybe 1/3 only open. So, of course, if you have some trouble with perfusion of the myocardium and these small vessels are occluded in many areas, and you might actually die of a heart failure. But this is not a heart failure by arteriosclerosis or something like that, but it's in the larger sense what we call small vessel disease. Small vessel disease is also detected in some cases of intoxication with other materials, and in this case apparently it's a spike protein.
In this next case, Professor Burkhardt observed a subarachnoid hemorrhage in a 29-year-old male who received 1 dose of AstraZeneca and 1 dose of Pfizer. He died 46 days after the second injection. Most cases of subarachnoid hemorrhage arise from structural defects of brain vessels, most often aneurysms. However, no such defects were found in this case, nor did the patient have any other known illnesses. First of all, before we discuss the image from your study, can you just explain briefly what a subarachnoid hemorrhage is?
Well, the brain is covered by a very delicate kind of skin, and inside there are small vessels which also supply the brain. And in this image, actually, this is the surface of the brain. You see the surface of the brain here, and there's this very delicate structure, which is the subarachnoidal membrane with a small vessel here. And then we have the brain groove here. And here a little bit larger vessel is shown, and you can see that the vessel wall, if you would look at it at a high magnification, is dissolved, and you can see that there's blood also in the surrounding of this vessel. So this vessel apparently is not containing the blood anymore, but there's a hemorrhage. And in this patient, no larger aneurysm was found, because this type of subarachnoidal bleeding usually occurs or may occur in younger persons, but it is caused by genetic defect in the larger vessels of the brain bases. And this was not the case in this patient. It was not found. So he had a diffuse hemorrhage from inflamed and partly destroyed smaller vessels.
Do you know what symptoms that he may have had, and if not, what symptoms would one experience if they were suffering with this particular condition? Would they have any symptoms?
Well, actually, this was one of these cases. He was suddenly unconscious, and reanimation was done in the hospital, but he died. Actually, they could not.
Did he die suddenly?
So, yes, actually. Excuse me.
Sure.
Before he was unconscious, he had convulsions.
Okay.
and after that, and he was resuscitated and died in the hospital, and came dead to the hospital.
At age 29, otherwise healthy male?
Yes, yes.
Okay. Now, what persuaded you to conclude that it was possible that it was the COVID-19 vaccine that was perhaps associated with this death, this ailment?
Well, actually, in addition to these lesions in the brain, we found mild myocarditis also, which would be very unusual that you have a brain hemorrhage and a myocarditis. And we had endothelial lesions, damage and destruction of endothelium, especially not only in the brain, as I showed you, but also in the myocardium. So this is a apparently toxic effect, and the assumption that this is a toxic effect mediated by the spike protein is made further very probable, because we could show the spike protein in these lesions. And by the way, this is the person where we found the spike protein in the testis, in the spermatogenic cells.
Yes, and we will get to that, but I just want to speak generally here. You were able to find several abnormalities in one patient.
Yes.
And what does that suggest to you?
Well, that would suggest that he did not die of a brain aneurysm, but he died of multiple lesions, which probably are caused by the same, in this case, toxic agent.
Thank you. I now want to have you take a look here at some of the findings from German-Swedish pathologist Ute Kruger. I think it's important to highlight that there are other pathologists as well who are doing this work, who are seeing the same abnormalities. So I'd just like you to provide a comment on what's being shown here and its implications.
Well, actually, this is exactly what we see too. On the left, there's a normal artery. I mean, it's an H&E stain, so you don't see the elastic fibers. If you would have an elastic stain, you would see some defects there. And here you can see the inflammatory infiltration in the intimal part of the vessel, and there's no endothelium here to be seen. And if there's no endothelium, then thrombus is formed.
How are you able to determine if these lesions, which are tissue abnormalities, are a result of the COVID-19 vaccine or the COVID virus?
The pathogenic agent is in both cases identical, and especially the spike protein, of course, is induced by the vaccination, and the spike protein is also produced by the virus. So the levels of the spike protein is very much lower in viral infected persons, in contradistinction to those who have been vaccinated. And actually nobody knows how high these concentrations of the spike protein can be in the vaccinated. And of course we know it can persist for many months now and can be found in all organs. While in the normal infection, it usually stays limited to the aerodigestic tract. And in addition to the spike protein, of course, the true viral infection has other antigenic structures. And one of these other antigenic structures is the nucleocapsid. And so if we find the spike protein and the nucleocapsid, then it is probably the result of a true viral infection. But if we find only spike protein and no nucleocapsid, this is a very strong suggestion that this is a consequence of the vaccination.
How do we know that the spike protein expression is caused by the vaccination and not the virus? To best understand this, it is important to note that SARS-CoV-2 virus particles contain two major proteins. First, the spike protein, which is located at the surface of the virus particle. And second, the nucleocapsid protein, which forms a protective layer around the RNA genome. Therefore, virus-infected cells should make both of these proteins. Meanwhile, the vaccine only encodes the spike protein and not the nucleocapsid protein. This has been experimentally confirmed by German physician Dr. Michael Merz. How can we determine whether the spike protein and/or the nucleocapsid protein had been present in the patient's tissues? We can use immunohistochemistry, or IHC. This method allows for the detection of specific molecules of interest in the tissue samples by using specific antibodies. In this case, the molecules of interest are the spike protein or the nucleocapsid, respectively. We will here use the spike protein as the example. Let's now summarize this technique. First, an antibody which interacts with the molecule of interest, in this case the spike protein, is applied to the tissue sample. After allowing some time for the antibody to bind to its target, the unbound surplus is washed off. Next, a secondary antibody coupled with a catalytic protein enzyme is applied to the same tissue sample. This second antibody binds to the first one. After some more time, the unbound surplus is again washed off. Third, a colorless dye precursor, most often diaminobenzidine, is added to the sample. This dye precursor can be converted to an actual dye by the enzyme that is attached to the second antibody, and thus indirectly to the spike protein. The brown dye that is produced by the enzyme is insoluble, so it comes out of solution and is deposited close by. Thus, wherever there are deposits of brown pigment, we know that spike protein must have been present. We can perform the same procedure separately with an antibody that specifically recognizes the nucleocapsid. And now we're going to focus on the use of immunohistochemistry to detect vaccine-induced expression of the spike protein. Here we have two images, and these images come from Dr. Michael Merz, and they show the cross-sections through two small blood vessels. Can you explain what is being observed here?
Yes, I think these pictures illustrate exactly what I just tried to explain. I mean, you see on the top, you see small vessels, and already from this magnification, you can see that these vessels have an endothelial damage. Then you have the brown stain, and that means that immunohistochemically spike protein can be seen here. Below, the same vessels are seen, and they are stained for nucleocapsid, and you see the same lesions, of course, of the endothelium, but there's no staining. So this is a very strong indication in considering everything that you see, that this is a specific lesion by the vaccine produced spike protein and not by the virus produced spike protein.
In each of the cases, did you perform nucleocapsid control?
In all the cases that we have a positive spike protein reaction, we do the nucleocapsid with negative and positive controls. And if the spike protein is negative, of course, then we don't have to do the nucleocapsid because this is not relevant anymore. And actually we have, I think, 2 or 3 cases where we do have expression of the nucleocapsid. So in these cases, of course, there might be an additive effect of the vaccination and a viral infection, either before or after vaccination. And in our observation, these are the cases with the most severe side effects.
When somebody has been infected and then also was vaccinated, you see the most severe symptoms.
We cannot prove this scientifically by now, but this is just a case observation.
Thank you. That is a very important point that you raise here. While detection of spike protein clearly points to vaccine causation, Professor Burkhardt does not rely on this method alone.
Let me stress this, we never make this diagnosis just solely, only dependent on our immunohistochemistry. We only make this diagnosis if we have lesions which are distinctly positive and which by themselves are already more or less absolutely typical of vaccination damage, like elastica destruction.
This next image shows the expression of spike protein in the coronary artery of a 24-year-old male with no known prior illnesses. The young man received 1 dose of Johnson & Johnson and 1 dose of Pfizer. He died 56 days after the second injection. Can you just describe the significance of this image?
Well, you see the vessel wall on the left lower corner, and then you see the split in the middle. And here you can see a dense infiltration of lymphocytes. These are the small dark dots. And then you can hear this is a thrombus. And we did the spike protein, and it is positive in some of these inflammatory cells. And maybe we are not very sure what it means in the thrombus, but this might be an artifact. And this, by the way, is an artifact too.
But given that this image shows a lot of brown pigmentation, does that mean that there is a lot of spike protein being observed here?
Yes, yes. I mean, here in this line should have been the endothelium, protecting the blood which has been flown here, and this is the wall. And here the endothelium should have made a borderline between the two, and it is destroyed. There's inflammatory infiltration, and in this context also some thrombocytes have been attached, and then the process of thrombotic event was started.
What role did the spike protein have in the formation of the blood clot here?
Well, it's the endothelial damage. It's a destruction of the endothelium, whether it's by toxic or by immunologic interaction. It's not clear in every case, but in any case, there's no endothelium here.
Okay.
Just like that.
It is now well established that there is an increased risk of myocarditis after vaccination. Professor Burkhardt further established in this particular case that the severe myocarditis observed in the patient was spike protein induced. The patient was a 54-year-old woman who died 11 days after receiving a second Pfizer injection. I'll let you just describe here what we are able to see.
Well, on the left side, of course, you see a heart muscle with very pronounced disintegration and destruction of muscle cells, and there's a dense infiltration again of these small dots that are the lymphocytes, and in contradistinction to an infarction, there are no neutrophil granulocytes, which are the cells that are predominant in myocardial infarction. And on the right side, it is just shown that the spike protein is found in these destroyed muscle cells. In this case, the autopsy done by the pathologist was death by cardiac decompensation, which of course contains everything. I mean, it is not an etiological diagnosis, it's just a statement of a plausible cause of death.
Another pathologist, Dr. Michael Mertz, is also using immunohistochemical staining to detect spike protein in the tissues of vaccinated persons. These two images are from Dr. Mertz's published study, in which he examined the brain tissue of a vaccinated patient who developed myocarditis and encephalitis post-injection. The patient was a 76-year-old male who had received 1 dose of AstraZeneca and 2 doses of Pfizer. He died 3 weeks after the 3rd injection. Would you like to just comment on what is being observed here? On the left, we see the spike, and then on the right, we see the nucleocapsid control.
Well, yes, you see the brain tissue, and the larger cellular elements are the nerve cells, and on the left side you see a positive staining, in this case brown staining of some of these neural elements, and on the right side again a negative finding. So this is a strong indication that these damages are caused by this vaccine-induced spike protein.
So just to reiterate one more time for the listeners, the nucleocapsid control, which is being shown here on the right, indicates in this case that the expression of the spike protein was caused by the COVID-19 vaccination and not the COVID-19 virus.
Yes. This in the context of the whole...
In the context, again...
Of all findings and all clinical data, yes.
Yes, thank you. Okay. Now we can have a discussion about encephalitis, and I want to talk about a case in which a brain biopsy was done. And to be honest, I was very surprised by this particular case because I did not know that one could have a brain biopsy. From my understanding, it's done very rarely. So can you talk about why in this case a brain biopsy was done on this particular individual?
Well, actually, a needle biopsy of brain lesions actually is something that, yes, it must be very rare, because in 40 years I have not had a needle biopsy of the brain. What I did have is fast frozen sections during open surgery of the brain. Of course, if they open the brain and find a tumor or something, and then they make a fast frozen section to get the diagnosis during the surgery. But in this case, she had severe neurological symptoms. Of course, they did investigate the spinal fluid and everything, but they did not come to a conclusion. So there was a suggestion of a tumor in the brain, and they suspected a malignant lymphoma. And a malignant lymphoma can be very successfully treated if you know the exact type. So they were desperate to find out what type of a lymphoma was here to give her the right treatment. But then they did this needle biopsy, and no tumor, no cancer was found. This has been confirmed by several university pathologists who looked at it. But instead, they found a very pronounced vasculitis and also a concomitant encephalitis. On the left side, you see this. This is the needle, the contents of the needle that was used to get the tissue out of the brain. And on the right side, you see a high magnification. And also in this overview, you can see these spots where there's a more dense aggregation of cells. These are inflammatory cells, and they are located selectively around small vessels. So this is definitely a vasculitis, a lymphocytic vasculitis, and also some inflammation in the surrounding tissue could be found. So there was also a concomitant encephalitis. Malignant lymphoma was excluded, and vasculitis and encephalitis was confirmed, and I suppose she is treated now probably with some anti-inflammatory agents.
Professor Burkhardt also tested this same brain biopsy sample for the spike protein using immunohistochemistry.
On the left side, you see the spike protein, and it is selectively expressed in the vessel walls of the small vessel. It's brown stained, and there's not much background in this case. And on the right side, you see the nucleocapsid, which is absolutely negative in this case. And in the middle, you can see that these large nerve cells also express the spike protein, so this is an indication of a concomitant encephalitis.
Michael Mertz was also able to find in his case study of a 76-year-old man he found that this individual who was also vaccinated had encephalitis as well. So is encephalitis potentially a common ailment associated with COVID-19 vaccination?
Well, apparently, yes. As I said, we find minor lesions of the small vessels, and if the small vessels, or if the vessels are inflamed, the so-called blood-brain barrier breaks down, and that means that the vaccine contents can enter into the brain. And I think just recently some Japanese investigators found that the spike protein is selectively toxic for ganglion cells, for nerve cells. Once it gets into the brain, it may cause encephalitis.
This image shows the strong expression of spike protein within the spleen of a 94-year-old female who died 67 days after the second injection. Spike protein expression in the spleen is notable for two reasons. Firstly, we know that vaccine particles tend to accumulate in the spleen. Secondly, it is a major lymphatic organ. Spike protein expression in the spleen may therefore result in the killing of many lymphocytes, which would in turn lead to immunosuppression. Can you explain what is being observed here with this case, and why does the spleen show such strong expression of the spike protein?
Well, actually, of course, this is one of the aims of the vaccination. They want to provoke the immune system to produce spike protein, but in this case it was a very strong expression, and not only in the spleen. I just took this picture to show that the vaccination does what it should do, but it does too much. It's in some cases it's what we call lymphocytic amok.
Yes, this is a term or phrase that you have coined, really. You coined the term lymphocyte amok. What do you mean by that?
Well, I mean that the lymphocytes are overstimulated. I mean, the vaccination wants to stimulate them, of course, but in some cases they are overstimulated. And clinicians talk about hyperinflammatory syndrome, and this may be destructive in many organs. And this always has a danger of an autoimmune disease, which we talked about earlier, about the thyroiditis and so on.
So how serious is immunosuppression, for example, and how does it typically present itself in patients who may be suffering from it?
Immunosuppression is something that is not conspicuous in our cases, because we see overstimulation like in this picture, and sometimes we see depletion of the spleen and lymph nodes. But of course, by the morphological structures, we cannot make any statement about the state of the immune system.
Okay. So this next case involves a 35-year-old woman who was vaccinated and started to experience skin lesions, and this has had a severe impact on her life. I have heard you speak about her case publicly before. Can you just explain for us what this woman was experiencing and how this impacted her quality of life?
Well, first of all, she had several severe side effects, but the one side effect that affects her or reduces her quality of life the most are these skin lesions. She had an absolutely healthy skin before, and now she does not want to enter into the swimming pool or in the open. And actually, the whole skin is covered with these pustular lesions. And we took a biopsy, and you can see on the left side that this is something that is related to what we call a lichen planus. That is an autoimmune disease destroying the basal cells. And you can see that here these cells are specifically stained by the spike protein, and they are vacuolated. That means they are damaged or even dead. And then you can see the spike protein also in this lymphocytic infiltrate. The lymphocytic infiltrate is the one that attacks the basal cell.
So you did find the spike protein expressed in the skin biopsy. So I do want to ask you, could skin biopsies also be useful in potential vaccine damage to organs other than the skin?
Yes. Well, first of all, I said this is a lesion that is related to what is known as lichen planus, but it is an atypical type because in addition to these destructions of the epidermis, we also find a vasculitis, and this is not a typical feature of this disease, lichen planus. So we have an atypical autoimmune disease with concomitant vasculitis. And we get a lot of skin biopsies now with the question, and there are two different types of questions. One are the persons that have lesions of the skin, and there we find atypical lichen planus and what is called pemphigoid lesions, which are autoimmune diseases. They have lesions of the skin, but then we have other persons that do not have any skin lesions, but other side effects. And here we find this vasculitis of the skin. And this is very clear, and it is also associated with spike protein expression in the endothelium. So there are these two possibilities.
Many women have experienced and reported on menstrual disruptions post-vaccination, and you have been able to see this in your own studies. In particular, there was one woman, a 52-year-old woman, who was still having a menstrual cycle, and post-vaccine, she began to experience very heavy bleeding. These three images here are showing the tissue of the endometrium, which is the lining of the uterus, and I see that on the right, we do see the nucleocapsid control, which is important because, again, that is able to indicate that the expression of the spike protein here is a result of the COVID-19 vaccine and not the virus, but I'll let you take it from here. What are we seeing in these three images?
Well, first of all, let me add this fact. This woman not only had these disastrous bleeding problems, but she also had other very severe side effects, neurologically, blood perfusion, and so on. She's really very sick, but nobody took her seriously. So this abrasio was done. And we can see here on the left side, we see the glands of the endometrium, and you can see that the epithelial cells are positively stained. The background, the stroma, what we call it, is negative. So this is an indication that this is a specific stain. And also in this case, the nucleocapsid is negative. Now what you see here, these are red blood cells, these are vessels. So this is not an immunohistochemical staining. Mm-hmm. But what is very striking, and I have never seen this before, and I looked into textbooks about the formation of lymphofollicles, small lymph nodes, so to say, in the endometrium. And there are some references to lymphoplasmacytic endometritis, but I didn't find the term lymphonodular endometritis. And actually we find, I think even non-pathologists may see that this is a small nodule here of dense aggregated cells. Mm-hmm. These are lymphocytes. And this you would call a lymph follicle. And in the middle here, you can see these stained, and there's a gland. And this gland expresses the spike protein. So actually, we have the autoimmune attack in flagranti here in the endometrium.
Great explanation there. So this, what we're seeing in the middle image, you say is highly unusual.
Yes.
What you just described. Okay.
Yes.
And the excess bleeding that this woman had experienced, that is attributable to the COVID-19 vaccine?
Well, I think this is a very strong case. I mean, why would she have of course, it could be menopausal bleeding, but as I said, she has other very strong symptoms, side effects.
Lymphocytic inflammation and spike expression is also observed in the testis. The image on the left, stained with HE, is from a 55-year-old male who died 7 days after receiving a second Pfizer injection. The image on the right shows spike protein expression in the spermatogonia, which are the cells that produce sperm. This sample is from a 29-year-old male who died 46 days after his second injection. As discussed earlier, the immediate cause of his death was a subarachnoid hemorrhage.
Well, first of all, on the left side, you see a distinct lymphocytic nodule forming around the blood vessel. And so this is lymphocytic vasculitis, and this is a section from the testis. And on the right side, you can see the spermatogenic tubules of the testis. And you can see that the stratification usually is very regular, and you can see it is disturbed. And usually in the middle, in the lumen, there should be lots of spermatocytes. And you can see a few spermatocytes here. These are the very small elements, but what is conspicuous is that these larger elements, which are the spermatogonia, with the cells that form the sperms, are detached and in the lumen of these small canals.
The image on the right side, labeled spike protein, do you see sperm cells in this image here?
If you look exactly, you can find one or two in one of these canals, but usually there should be at least 20 or 30 or even more. Usually it's filled.
Okay.
And especially the stratification is completely destroyed.
Would you expect someone to have symptoms if they were to be experiencing this complication?
Well, I wouldn't think that they have any dramatic symptoms, but probably sexual activity would be lowered because it is connected with spermatocyte production. And by the way, we also find expression of spike protein in the prostate gland, so this is also part of the semen. So it should be affected, but probably not everybody would take a record of this.
During a recent speech in Stockholm, you said that you would recommend a woman of childbearing age to not become pregnant by a man who has been vaccinated. Can you expand further on what you meant by that?
Well, actually, I wanted to add something, but I was interrupted by a big applause to this. If I may make a personal comment, this is not a scientific comment. If I were a woman in fertile age, I would not plan a motherhood from a man who has been vaccinated, unless I think these pictures are very disturbing for me. And I said, unless, and then I stopped, and I get many telephone calls of women who say, well, what did you say, unless what?
Yeah, so right now, why don't you tell us, what else were you going to say at that moment?
I would at least wait for 2 or 3 cycles of spermatogenesis. Now, the cycle of spermatogenesis is about 70 days, so I would wait for, let's say, 3/4 of a year or something like that. And before this, I would suggest to make a spermatogram examine the sperma and especially the motility, motility of the sperma. So I think this would be an indication. Now, as far as I have seen, and I have not only seen the testes of this young man, but also of older men, but of course they are more difficult to interpret. But as far as I can see, the spermatocytes themselves do not express the spike protein, as far as I know by now. Anyhow, this is of course an alarming finding.
Sure. And according to data submitted by Pfizer to the Japanese health regulator, the vaccine particles do distribute to the ovaries. But in your own studies, were you able to find spike protein expression in the ovaries?
Yes, we did find this. Unfortunately, these are mostly elderly women where we get specimens from the ovary. Unfortunately, during autopsy, the ovaries are often not taken for histological examination. So this has to be interpreted very cautiously. We find it actually mostly in the vessels, in the vessel walls of the ovary. But we are behind this question.
Professor Burkhardt, a few times throughout this interview, we did mention the elastic fiber, so that is now what I would like to focus on. And you have been able to show that there is damage to the elastic fibers caused by the COVID-19 vaccines. But before we discuss some of the images, I would like you to describe, in simple terms, the function of elastic fibers in the body.
Well, actually, the elastic fibers are a very late development in the evolution of life. And these are structures that, like a rubber band, have elasticity. And these fibers are formed in the first years of the life. And around puberty, no more or only very little elastic fibers are formed anymore. So it's a permanent structure. It's very important for the arteries, especially the main artery, the aorta, because it gives elasticity. It is important in the lung because it gives elasticity in breathing. And it is also important in the skin because it gives the baby face appearance of the skin. And if you get older, these elastic fibers of the skin are destroyed by ultraviolet variation. So that's why we look older when we get old. But there have been very convincing reports that people after the vaccination suddenly appear to look much older. Now, this may be due to psychological factors too, but we definitely have proof that these elastic fibers, in some cases, are profoundly destroyed in the skin. And the other organ that is very important in view of elasticity are the arteries. I mean, the heart contracts and there's a rise in pressure. And this pressure is taken up by the elasticity. So the blood pressure is not going up indefinitely, but it is taken up. And then when the heart is not contracting, the arteries flow the blood to the organs.
The walls of the aorta and of other major arteries are rich in elastic fibers, which are arranged into stacked layers or lamella. These elastic lamella are essential for the vessel's ability to withstand the pulsating blood pressure. Professor Burkhardt found that in many of his cases, the elastic lamella were damaged and disrupted, particularly within the hot spots of inflammation.
If the arteries are not elastic, we would have peaks in the blood pressure, and these peaks, of course, may lead to rupture, and we already talked about rupture of arteries in the brain, in the aorta.
Damage to the aorta and to other major arteries was also apparent in patients who had not suffered overt failure or rupture to these vessels. This image shows the aortic wall of a 29-year-old male who died 67 days after receiving the second Pfizer injection. The tissue sample has been treated with a special stain which highlights the disrupted elastic lamella. The image on the left shows intact elastic lamella for a comparison. Can you describe what we are viewing here and the significant findings related to the elastic fibers?
Yes, well, on the left side you see that the normal arteries, especially the aorta, the main artery of the body, is constructed of a very regular stratification of myofibroblastic cells and smooth muscle cells and these elastic fibers. This is very important, and we have very alarming findings. First of all, destruction of elastic fibers in the arteries, especially in the aorta. Sometimes very small lesions. You don't see this in a radiograph. Patients with these lesions don't have any symptoms, but those that have further development, which have a total media necrosis of the elastic fibers, they may die of aortic rupture. And we have, as I said, 5 cases of this.
Can you explain in simple terms what media necrosis is, or how it would present itself?
Well, especially the larger arteries, especially the main artery of the body, the aorta, is made up of 3 layers. The intima, this is where the arteriosclerosis and cholesterol deposition happens. Then we have the media, which is where the elastic fibers and the myofibroblasts, the smooth muscle cells, are located. And then we have the adventitia, where there are the so-called vasa vasorum, which supply the vessel wall with blood, oxygen, and so on. We have the outside supplied by vasa vasorum and the inside directly by perfusion. But then we have the middle, the deep media. And the deep media is affected by toxic agents and by infectious toxic agents. Now, 100 years ago, the necrosis, media necrosis, was very often seen in syphilis. It was infectious toxins, and it also led to rupture and death. And this is probably because this is what we call Achilles heel of the aorta, where toxic agents may act there especially. And there's also some kind of a food poisoning, which is called laturism, which by now we don't see very often. In my first years as a pathologist, I had a case where I saw this. And it's also a toxic agent in some plants, Kichererbsen, a kind of chickpeas which may be toxic. I suppose that this is a phenomenon which is similar to what we have seen in the past. So there's a toxic and maybe also immunologic attack in the area of the arteries where there's a weak point. And there may be local bleeding with hemosiderosis, iron deposition, and there may be perforation. And there may be, probably in many cases, small lesions may heal. But then the elastic fibers cannot be replaced by elastic fibers once you're older than 15 years, let's say. And so there's a scar. And if there's a scar, the artery loses its elasticity, and so the rise in the blood pressure during contraction of the heart is very high, and it goes down, and it goes up, and it goes down, and it leads to probably the brain arteries are the most sensitive arteries to rupture and death by cerebral bleeding. And now my fear is maybe in somebody who has a scar in his artery, maybe he will die in 5 years from cerebral bleeding, but nobody will associate this with the vaccination, and nobody will even examine the aorta, the main. This is not a standard to examine the aorta. There will be a high number of cases where nobody sees any connection with the vaccination, although it is probable.
As Professor Burkhardt mentioned earlier, damage to elastic fibers was also commonly found in the skin of vaccinated persons. He observed these changes in biopsies, that is, in skin tissue samples of living patients.
Right now, I'm systematically reviewing our biopsies from the skin, and I have one example here, and you see on the left side there's a very delicate network of very fine elastic fibers. They are black. On the top is the epithelium of the dermis, and here you can see this man. He's 38 years old, and he has a vasculitis of the skin. Here you can see there's these very delicate black lines here. These are the remnants of the elastic fibers, and there's no network below the basement membrane.
Let's now shift our focus back to clots, and we did discuss this a little bit earlier, and I think that the topic of clots has received a lot of public attention and has generated a lot of public interest. I want to first clarify, before we discuss a few images, that there are 2 types of clots associated with the COVID-19 vaccines. Can you explain those 2 clots?
Well, first of all, there's the so you may call normal thrombotic clot, which is formed by thrombocytes and fibrin, and which, as I said earlier, is of course a kind of a healing of traumatic events. I mean, if
someone gets a cut,
if you cut your skin, of course there will be a thrombic formation, and then the endothelium regenerates, and this is a normal process.
So that's one type of clotting. That is, yes, when, for example, somebody has a cut, it bleeds a little bit, but it eventually stops. That's, yes, one type, and that's considered normal. Yes. And the second type?
Well, the second type is a type that has not been observed before, actually. Okay. And actually the first notice of this came from the United States. I personally have been in the United States, and I was a guest for almost 1 year with an undertaker. And actually there I got my first experience with dead people. And I know that from that time nobody ever observed these casts in the vessels, because in the United States, different from Germany, where people are buried or burned, they embalm. All deceased persons are embalmed, and this makes it necessary to open the arteries or veins, and put fixation fluid into the body, so the body is embalmed. Soon after this vaccination campaign started, there were reports from undertakers in the United States that they observed these very strange casts in the blood vessels. They were long, elastic structures, not adherent to the wall, so they are not caused by normal vascular damage, and they are very extensive. So just from the first report that I read this, I was convinced this could not have been the cause of the death, because I mean, if all your arteries are blocked, you would die before all this has formed.
These clots formed post-mortem, after death.
I'm absolutely sure they formed after death, and they were associated with the cooling of the body. All dead persons have to be cooled before they are embalmed. These are the two things that I stated. They cannot have been formed intra-vita during life, and they have been formed by cooling. Now we come to the point that we have been observing these phenomena in living persons. And this is, I think, something that has not been looked into before.
In cases in which abnormal blood clots were observed in living patients, it is important to note that the clots were localized events and therefore more survivable. In this case, the patient is a woman in her early 40s who was an avid marathon runner. After receiving one dose of the Pfizer vaccine, the woman began to experience blood perfusion problems and sensitivity to cold temperatures.
The angiogram showed double-barreled arteries in the legs. So this is the phenomenon that I described before, that the media necrosis, in this case it was not in the aorta, but it was in the lower leg arteries. This lady was fortunately in a way that this media necrosis did not rupture, but it found its way back. So it's well known that there are two ways. Either if you have a dissection of the aorta or a large vessel, there are two ways. Either it goes outside and you die by bleeding, by hemorrhage. And the other way is that it finds its way back at some other location, and then you have the circulation is again possible, but you have, of course, trouble with perfusion. And this lady, actually, she was active marathon runner. She participated in marathon runs, and soon after this vaccination, she could not walk anymore for some time and had very severe problems. She did all kinds of therapeutic measurements like plasmapheresis and things like that. And she is better now, but it relapses. This is after the vaccination that shows that there's a profound damage of the perfusion. I mean, at some times she could not walk.
She couldn't walk
anymore, no.
Wow. And 40 years old, otherwise healthy.
Yes, as I said, a marathon runner.
Now this is also
Yes.
a point of interest, this image here on the left, which shows the blood after it has been separated and cooled. What is this yellow structure that we see at the top of that vial? Can you explain what's happening here?
Yes, well, let me first say this. She had a biopsy of the skin, and in the skin biopsy we saw a vasculitis, we saw necrosis of endothelium, we saw expression of spike protein. And then she called me and said, well, the doctor took blood for analysis, centrifuged it, and put it in the refrigerator. And the strange things happened that in the upper part where the serum is, there formed this strange clot, which apparently is not a thrombus because it's white, as you see. There's no erythrocytes in there. And it is like a jellyfish and a little bit sticky.
Professor Burkhardt also examined the clot under the microscope, which is shown here. He used a special staining technique that highlights fibrin. The extracellular proteins within the clot were identified with modern biochemical techniques in another laboratory.
We found it was almost cell-free aggregation of small microfibrils, probably unmature fibrin. The thing is, it's definitely not a normal thrombosis, and we have fibrin, which is a constituent of of a thrombus. It's only on the surface. We have inside these small fibrils, and this is the surface. You see here this slightly bluish are these very delicate fibers. Mm-hmm. Which probably are some pre-stage of fibrin. Mm-hmm. Then on the surface, you see there is only on the surface thrombocytes, there are some lymphocytes, there is mature fibrin on the surface, and which is most important, there are CD61, which is a constituent of endothelial cells. So the contents of endothelial cells comes into the blood. And under certain circumstances, apparently after cooling, these may form these structures, these clots. Then we had proteomic analysis done by a friendly laboratory, and they found that the proteinous composition of the serum and of the clot differed. And in the clot, there were 139 proteinous structures that were not in the serum. And these were extracellular matrix, collagen, elastin, and some other structures, especially CD31, which is related to endothelial contents. We consider now, and we have, of course, we have more cases to examine. We have some more already now. We concluded that these clot formations are an indication that in the past there was an endothelial damage, and if it's still forming, it's an ongoing endothelial damage, and through the endothelial damage, proteins and matrix constituents of the vessel wall come into the blood and circulate in the blood. And under certain circumstances, they can form these clots.
And you were seeing this in several people who were vaccinated, these types of clots. Is that correct?
Yes.
Okay.
But at this moment, we don't have a systematic evaluation, but it seems to be the case that it is associated with vaccination.
In all of your years of pathology prior to the rollout of the COVID-19 vaccinations, you did not see this type of blood clotting. Is that correct?
That is correct, yes. And actually, we have one specimen which was taken from a person who is still living, and they did angioplasty, and they removed such a clot outside of an artery. And this is definitely associated with temperature, because this lady especially, but I have heard it also from other persons, they feel or they have no major problems as long as the temperature is good. So, but if it's below 25 degrees, they have problems with their hands maybe.
So is it their circulation?
Apparently,
they have
yes.
problems in the cold temperature, and multiple people who have been vaccinated are reporting this?
Yes.
Okay. Next, Professor Burkhardt and I discuss his findings and his work more generally. He provides his perspective on the scientific community, academic science, and the public health industry. He also reflects back on his career and shares his motivation for doing this work. All right, Professor Burkhardt, I just want to have a general discussion with you about the findings, about your work. And first of all, I would just like to know, to what degree of certainty are you able to show, or that you can say that the damage that you have observed is associated with the COVID-19 vaccines?
Well, as I said, there's not a single test or a single histological change or immunohistological change. It's always the combination of all the findings that we see, and of course we have to take into account the medical history. In these 75 cases now we have 78% where we are certain that the death process was in some way influenced by the vaccination. Now, this does not say that all these people died of the vaccination. The death process is complicated. In persons over 50 years, of course, there's always there are many organ lesions that can be made responsible for death, but in these 78%, we are sure that it played a major role, and that these people may have survived without vaccination for, I would say, at least 6 months. Nobody can say this exactly, because nobody can see into the future.
Sure.
But they would have survived for some time. By the way, in our first pathology conference, we had only 15 cases examined, and at that time we came to the conclusion it is 80%. And now we have 75 autopsies examined, and now it's 78%.
And this is an ongoing project?
It's ongoing, yes. These figures may change, but the trend is obvious, and I don't think there will be anything that will prove us wrong.
When you take a step back and look at all of your findings, what are the conclusions that really stand out the most to you? Just speaking generally, if you could just describe what is the most significant.
The key is the endothelial damage and the vascular, and after the endothelial damage, the vascular damage, which may be in the heart, in the brain, and also in other organs, but these are the organs mostly affected.
Now, some pathologists may be inclined to disbelieve your findings without independent confirmation. So has there been any other pathologists or medical professionals who have been able to confirm your findings? And if so, can you name who those pathologists might be?
I have many colleagues which confirm my findings. Unfortunately, German pathologists don't want their name to be published, but just to name some international pathologists, I mean, you probably have heard about Ryan Cole. I have discussed with him in Vienna, in Stockholm, and I will meet him in Brussels next week. He sees the same things, and well, he made this remark which I can subscribe 100%. He said, if anybody would see only 1% what I see in the microscope of vaccinated persons, vaccination would be stopped immediately. And this is 1%, and I see 100%, and he sees 100%.
It's very important to highlight that there are many pathologists out there who are seeing exactly what you are seeing here, and I'm very curious as to what you think we could expect in the future if we continue to vaccinate people against COVID-19 with gene-based vaccines and with gene-based vaccines in general. What health complications and trends do you see arising if we continue to go down this pathway?
Well, I think this pathway has to be stopped immediately.
Are there any other health issues that you could see arising in the long term in someone who has been vaccinated?
This refers to problems that I, as a pathology, cannot see, but as a physician, medical person, of course, I have the very strong suspicion that changes in the genetic construction of our cells will be changed, and this is something that has never been done in history of mankind. So I think it's absolutely it has to be stopped immediately. And before, I mean, even in my, I just, yesterday I read a textbook that was written by my teacher of pathology, and this was in the 1980s, and he said, well, messing around with the DNA has many promising aspects, but it has grave problems, and everybody must be very careful. And I cannot understand that physicians in all over the world just ignore this and believe some people who say, well, this is absolutely without any side effects.
You have had a long and successful career in pathology. How do you think that we got to the point in which academic medical science is unable to understand and correct the serious mistakes that have been made with regard to the handling of the COVID-19 so-called crisis and also the COVID vaccines?
I think it must have been in the 1980s that the system of recruiting university professorships was changed. I don't know why, and I don't know if there was any intention behind this, or if this just was a normal course of evolution. I don't know, but I'm definitely sure that the generation of my teachers of pathology and medicine, and I may be one of the last of this generation, that this was a different and critical generation, and now we have what we call in Germany Systemlinge, that's the system-conform persons. And I mean, everybody should have cried out when somebody says, you never have to question this. I mean, questioning is the essence of any science. Actually, only now I have come to the conclusion that the academic world has changed in the last 20 to 30 years. It's completely different from the way it was when I was at the university. I would never think that my teachers of pathology, like Professor Cotier, which is a very well-known Swiss pathologist, that they would have in any way gone along with all these things today. And I can only have the notion that something went wrong, and the selection of what was once called the experts has changed in the last years. So I shook my head already very early when in the television so-called experts came out and say this thing should never be questioned. I mean, this is actually a person who claims to be an expert and a scientific person who says this fact should never be questioned. He does not belong to the scientific world, in my opinion. The so-called experts, I think they have themselves proven wrong. I mean, there are some people who said, well, very soon in Africa, when the COVID so-called pandemic started, they say, well, people in Africa will die by the millions. And in Africa, almost nobody dies of the COVID, but here we do. We had some.
You know, and what were your thoughts about the so-called pandemic and the hysteria that was being pushed onto the public in early 2020. I think a lot of viewers will be curious as to what you were thinking in those early months of 2020 when this was really being reported on extensively in the media.
Well, I did not panic at all. There were a few weeks where I thought, well, we should be careful. But I think in March 2020, at that time I thought, well, maybe it's better to be careful. But already 6 weeks after that, I heard the reports, and it became clear to me this is absolutely fraud. There's nothing to it. And I was never panicked because as a pathologist, I had autopsies every winter of, let's say, 4 or 5 people who died of normal flu. We did some precautions, but we did not run around with mouth protection or anything like that, and we did normal washing of the hands.
Now, early on during the so-called COVID pandemic, many pathologists were prevented from performing autopsies on patients who were suspected of having died from COVID-19, or COVID-19, the virus was listed as the official cause of death. Why do you think it was that these pathologists were not allowed to perform autopsies on these bodies?
Well, this is actually a scandal by itself. This was the second point when I became an unbeliever of all this, and I doubted the truth of all things that were taught to us, because if you have an unknown disease, the first thing that you do is that you order to do autopsies. And this is actually a shame to all pathologists, especially in Germany. I mean, they should have gone, what do you say, I go ape? No.
I get it, yes.
And they should have gone to the government and said, this is absolutely unscientific. And it was Corona in Hamburg, Professor Püschel, who said, well, this is not the way to do it. And he performed these autopsies, although there was a recommendation not to do this. And he had some very good results.
I understand that about a month prior to taking on this project, that is examining the autopsies in patients who died shortly after vaccination, as well as examining biopsies in living patients who were vaccinated, you were about to head into retirement.
Yes.
And you decided to take on this work without much recognition, without pay. Why are you doing this work? What motivates you to continue to do this?
Well, I think it's a human responsibility. I mean, if I have the knowledge and the education and the ability to see and make a diagnostic in the microscope, and I see something that is alarming and that may be a threat to, well, actually all humanity, there's no way out. Actually, I did not know what I was going into, and but.
Are you surprised by what you have found? Are you surprised by what you have found?
Well, yes, definitely. I never would have thought that this could be possible.
You never thought this could be possible?
Yes.
Wow. I want to now discuss a few points looking ahead. Now, the damage that you see from the COVID-19 gene-based vaccines, would you expect to see that same damage with other gene-based vaccines that are not necessarily to protect against the COVID-19 virus?
That's a difficult question. Apparently, in the COVID-19 vaccination, the main harmful agent is the spike protein. But if you read or listen to my what I publish or what I say, I always speak of spike-associated damages, because I can see the damage. I can see there's spike there, but I cannot say the damage is done by the spike. It could be that the spike is only one bystander, and that the lipid nanoparticles and other contaminations of the vaccines are responsible. So this is why I take this, I think, scientifically correct denomination, spike-associated damages.
Have you been able to observe, or rather have you tested for harms caused by the lipid?
Well, unfortunately, nanoparticles, as the word nano says, they are not visible in the microscope. They are beyond the microscope. So unfortunately, I cannot see them.
Okay.
And unfortunately, lipids are not accessible for immunohistochemistry, because they are not proteins, but they are lipids. But actually, we do have some not yet completely confirmed indications that these lipid nanoparticles may form crystalline-like formations with cholesterol. And we see these very strange particles in many organs of the deceased, that this is one of the things that we still have to clarify. I cannot make a definite statement about this, but this is something possible, and I would say as soon as we do not have a clear answer to this, if it's only the spike or if it's other, especially the nanoparticles, every vaccination with this modified messenger RNA should be stopped until we know more.
What causes some people to have severe symptoms after vaccination and others to not have any symptoms?
Yes, well, this refers to what you might call the vaccination paradox. There are millions vaccinated, and for many times it was said there are no side effects, but this definitely now has been withdrawn, and everybody admits that there are serious, even deadly complications. Now, there may be quite a number of explanations. One, of course, and I hope this is the case, that most or many of the charges were not efficient, especially if you look at these vaccination streets, as we call them in Germany. I mean, they were not cooled properly, and so on. Then there may be some charges that are different, so-called. I think there's a website about the charges that are especially.
Where's my batch, or
yeah,
find my batch?
Yeah.
How bad is my batch? Yes. How
Yes.
bad is my batch?
Genau, exactly. And then I personally think that it's a question where the injection was applied. I don't know if you have followed this, but in 2016, the WHO said that for vaccine injections, you don't have to aspirate to see if you are in a blood vessel. And they argued at that time that children, at that time mostly children were vaccinated, that the vessels in children are so small that you don't hit them with a needle, and it would be impossible to do this. But we measured the vessels in the deltoid muscles, and they easily, a needle of the type that you use for vaccination easily can get into these vessels.
So it's possible that some people, adults who have been vaccinated against COVID-19, the needle actually went into the blood vessel, and
Yes.
that is what's causing them to have a worse reaction.
Well, yes.
And then is it also too perhaps the amount of the vaccine contents that circulate throughout the body? Would that also have an impact on how severe someone's symptoms would be post-vaccination?
Well, I think it's absolutely clear that if you get what you call a bolus injection, is very dangerous. Bolus that means all the vaccine is directly into the blood. I mean, this is true for every toxin and for every drug. The higher the concentration, the higher the side effects, and this may be an explanation. And in February 2022, this recommendation by the WHO was withdrawn, and they said only for the messenger RNA vaccinations we recommend aspiration. And I mean, this is an admission that this is a different vaccination than all the other vaccinations.
Why would they make that recommendation? What was the justification for that?
I personally think they changed their recommendation because in September we had our first pathology conference, and I showed the pictures where I showed that the needle could be easily put into the vessel of the deltoid muscle. But they referred to a publication from a Japanese authors in the vessel, and the other group in the muscle. And those that were directly injected into the vessels had myocarditis in most cases and died. And this was published in July 2021. In February 2022, they withdrew their recommendation and said you must make aspiration. But actually, this was only a small notice in the ads in the German papers. I would be interested how many doctors that do vaccinations ever took notice of this. This was just, well, Feigenblatt, you say in German. It's just a cover-up.
Of course, many people are hearing this right now, and they are going to be wondering why. Why continue to keep these gene-based COVID-19 vaccines on the market if they are causing this significant amount of harm? Why do you think that is?
That's a difficult question, which just have to think about it.
Sure.
But I think the connection of political, scientific, and ideological aspects are responsible, and personally, I cannot understand how anybody who ever recommended this vaccine, this mRNA vaccination, can sleep soundly now. I would not be able to do this, and I can only consider that they are afraid, and they do not have the courage to come out and say, well, I was wrong.
Well, now I would like to give you an opportunity to address your colleagues, fellow pathologists, fellow medical professionals. What do you have to say to them?
Let me think a
Okay.
bit. Well, I think One of the things is always question what so-called experts tell you, because actually before this vaccination campaign, the word expert for scientific person I have never heard. I don't know how you define an expert. And now that the so-called experts have been proven wrong in so many cases, and even the general public maybe not believe in experts, now they have a new term, and they call it top scientific, so top virologists, top pathologists, and I think this is not in the interest of the people. You don't need top scientists, you need soundly thinking people with experience, with patients, doctors that have experienced in their everyday life. There were people dying by the flu for many years. Nobody ever made a pandemic out of it and locked people away because of that. I mean, I can very well remember that there was some kind of a panic in Reutling in the 1990s because there was a 7-year-old girl dying and an 8-year-old boy dying of the flu, and actually at that time I did the autopsy and I tried to give the specimens to be examined by a virologist, and nobody wanted to pay for it. Actually at that time I had to pay for it myself. So something went wrong. And
well, you know what that shows me? That shows me that throughout your career, you have been making an effort to do what is right. And that's exactly what you're doing right now. Even if it's difficult, even if you face challenges, even if there's no pay, you are doing what is right.
Well, I think this is the obligation if you are a doctor. And as I said, we don't need any top experts that influence the politics. We need soundly thinking people with everyday experience, with patients. It doesn't matter if they have experience with living persons or with dead persons as I have, but I mean, I have a sound, I think I have a sound judgment about what is happening. And the idea that there are some supernatural top whatever experts, this is just I cannot believe that people fall into this deception.
I would also like to give you the opportunity to address, once again, fellow pathologists and others who could help contribute to your work, perhaps help contribute with writing summaries or analysis of the work that you are providing. Do you have any message to others in your field?
In our pathology conferences, as we call them, which are always reports of the progress that we made, we have now defined many clear lesions, and we put some recommendations for procedure in autopsy, and I would just suggest and ask that my colleagues follow these recommendations. I mean, this is not a question of how to do the work, but how to be responsible for the work that you do.
What would you recommend that fellow pathologists watch out for?
Well, we definitely have some main and very convincing tissue lesions, and these are myocarditis, perimyocarditis, vascular damage, endothelial damage, and bleeding into vessel walls and in the brain, which may lead to death. And in any case, if an autopsy is done, the large vessels and especially the aorta should be histologically examined. And generally, an autopsy for a supposedly new disease can never be done without a histological examination of all organs. I mean, even if you think this is a clear-cut case of a heart infarction or whatever, or brain hemorrhage, you should examine the other organs, the genital organs. In some cases, not even the spleen was examined. Autopsy is not only a service to the doctors who were responsible for this patient, but it is a public service for our health system.
What would be your final message here today? Taking a look back at all of your work, what is a really important point that you want to leave the viewers with?
Just let me think a little bit. Well, actually, the main point is already said by my colleague Ryan Cole from the United States. I cited him and he said, well, if you only see 1% of what I have seen, and please, all my colleagues, look, and if you see this 1%, you must stand up and say this vaccination campaign has to be stopped immediately, and there have to be implemented strict regulation on any messing around with our genetic material.
What keeps you going? What motivates you to do this work under difficult circumstances?
Well, first of all, of course, I think everybody has a responsibility. Everybody today is calling for solidarity of our society, and I think the solidarity demands of you to step forward and come out when you see something is going wrong. I mean, if I see a car heading for a child on the street, I have to do something. I cannot just turn my back and say, well, bad luck.
All right. Professor Dr. Arne Burkhardt, thank you.
Thank you.
Professor Burkhardt has shown very likely or with certainty the role of the COVID vaccine in causing death or disease in the patients that he examined. He dedicated the final years of his life to helping bereaved families and living patients who were seeking answers and not receiving them anywhere else. He inspired deep affection, respect, and admiration from the many doctors, scientists, and medical professionals who worked with him to stop the harm and death that was and is underway. It is now up to other pathologists to follow his leadership and bring the full truth to light. It is on the rest of us to support them in the endeavor. Professor Arne Burkhardt demanded high moral and professional standards in the medical profession, and he himself set the example.